We talked a little bit about lifetime risk, and I think that's important when you're dealing with a younger population. If your lifetime risk exceeds 40%, they recommend, in addition to therapeutic lifestyle changes, also treatment with statins, allowing you, if you will, to treat that younger person. Well, the NLA, of course, you can never get consensus amongst different specialists. And the NLA, which is the National Lipid Association, this is also true for the International Atherosclerosis Society, the European Society of Cardiology, and the Canadian Society of Cardiology, felt that we should stick to the ATP3 recommendations, where you risk stratified people into low, moderate, and high, and that you actually had both an LDL and a non-HDL goal. I just want to address non-HDL quickly, although it's not in a lot of the guidelines. If you go back to the risk calculator, you do not put in LDL cholesterol. You put in total cholesterol and HDL. If you subtract HDL from total cholesterol, you're putting in non-HDL. So in developing the risk calculator, they realized that non-HDL was a better predictor of future vascular events than was LDL cholesterol. The population of people that we generally deal with have metabolic syndrome where their LDL cholesterols are not particularly elevated, but they have high triglycerides, low HDL, and their non-HDL is actually high. So it's important from a clinical point of view that you focus both on LDL and non-HDL. And whatever your LDL goal is, your non-HDL goal is 30 higher. And again, in the prior ATP3 guidelines, they address both LDL and non-HDL. Well, this is basically an algorithm. And it goes through what I've already said, that you risk stratify somebody. If the risk is greater than 7.5%, you treat them with statins. However, how about the rest of the group? What do you do with them? So how about the person whose 10-year risk is less than 5%? Or in the studies, we said that they had to be between 40 and 75. What happens if they're less than 40 or over 75? What happens if their risk is between 5 and 10%? Or if they're a diabetic and they're under the age of 40 or over the age of 75, what do we do with those people? Again, they didn't address these people because there were no randomized studies to answer the question. But it is possible for you to sit down with a patient and look at other variables that may help influence what your decision is. And they did say if the decision is unclear that you can use other things. So if somebody has a family history, perhaps that would support you up-titrating their risk and treating them. If they had an elevated CRP, again, that may influence you. Coronary artery calcium score is my go-to tiebreaker. It actually is probably the best risk predictor of all risk factors, because this actually determines your vascular age. If you have a set of risk factors and you have no coronary calcium, your risk is much lower than your nearest neighbor who has the same set of risk factors but has a lot of calcium. So if your coronary artery calcium score is greater than 300, or if your age-adjusted calcium score is greater than the 75th percentile, to me, that is an absolute indication to treat somebody for their cholesterol. And similarly, if you have an ankle brachial index which is abnormal, that shows that you have peripheral vascular disease, and you should also be treated. Of interest, they did not include carotid IMT in this, and there's been a controversy, and in fact, the use of carotid IMT is now a class 3 recommendation, which basically says it's not a recommended study. Okay, a lot of people also felt that after you start somebody on statins by the new treatment guidelines that you kiss them goodbye and never have them come back again. But that's not really true. What the recommendation is, within 2 to 3 months, you repeat their lipids and see if they attain the goal that you had. And remember, these goals were percentage decreases. If they do attain the goal, then the lipids should be reevaluated on a yearly basis to ensure that they continue to take the medication. However, if the person was not able to achieve the goal on just the high-dose statin, then there was recommendations to think about other forms of lipid-lowering agents. Of course, eventually the NLA and the ACC-AHA drank cocktails together, smoked cigars, and came up with a compromise position. I'm not sure that everybody would agree 100%, but it is a compromise and it's a little bit more forgiving. And they said that, first of all, you can either use percent decrease in LDL cholesterol, or as we were all grew up, you can use absolute LDL cholesterol, so that if somebody has established vascular disease, their LDL should be less than 70, and their non-HDL should be less than 100. And they also gave permission now, with a degree of support on both sides of the Republicans and Democrats, that you could use other things. So they suggested that if they weren't at goal, that you refer them to a specialist. You could use ezetimibe, bile acid sequestrants, PCSK9 inhibitors, mitomycin, lomidopide, and LDL apheresis. We do have LDL apheresis available in this institution. I'm not going to address these two drugs because PCSK9s have kind of taken over them. I'm not going to talk about bile acid sequestrants because they're horrible and most people do not tolerate them. So let's go on and talk a little bit about the 2016 recommendations. And they say that all patients with primary prevention should have LDL cholesterols of less than 100. And with diabetes, they suggest that you have a non-HDL of less than 130. Now, why did they just pick out diabetes? Because the diabetics are more likely to have high triglycerides and low HDL. But again, most of the people that you're going to deal with are going to have non-HDLs out of proportion to what their LDL cholesterol is. So my suggestion is that you pay attention to both. And again, they recommend that you have somewhere between a 30 and a 50% reduction in your LDL cholesterol. For secondary prevention, the recommendation again is an LDL less than 70 and a percent decrease of greater than 50. And that if you have comorbidities, oh, I only have 2 minutes left. Oh my God. So let me get to PCSK9, since those are drugs that you've never used. So the LDL particle attaches to the LDL receptor via ApoB. It then forms a vesicle, and in the vesicle there is degradation of the LDL particle, so the cholesterol returns to the cell and the receptor then goes back up to the surface. When you introduce PCSK9, however, instead of the LDL receptor returning to the surface, there's actually degradation of both LDL particle and the receptor. When there is a loss of intracellular cholesterol, there's actually activation of both an increase in the LDL receptor and the PCSK9, which doesn't make sense because LDL lowers cholesterol, PCSK9 increases cholesterol. So what are the recommendations for the use of PCSK9, which is a monoclonal antibody? It's used as an adjunct to diet and maximally tolerated statin therapy in people who require additional LDL cholesterol lowering, which includes those people with heterozygous FH and those people with clinical cardiovascular disease. And the FDA has not found, there are no studies to date to show that it affects morbidity and mortality. This is an important thing because 1 in 250 of your patients have FH. So how do you make the diagnosis? So although I said the LDL greater than 190, about 5% of those, 5 to 10% have actually FH. If you look at these particular levels, then about 80% have FH. An LDL of greater than 250, 30 or more, an LDL greater than 220, 20 to 29, and an LDL greater than 90 in the age of less than 20. The two drugs that are available One is Repatha, the other is Praluent. They're both given subcutaneously every 2 weeks. They're given subcutaneously because they're a protein, and if you ate it, it would dissolve in your stomach. There's significant decrease in LDL cholesterol over and above those people that are maximally treated, both with a statin or a statin and an ezetimibe, and in the bluish thing are those people with heterozygous FH, and these people are those people with clinical ASCVD. So why do we need additional medications? The reason is that statins to date still lead a significant residual risk. If you take a statin, you lower your risk for a vascular event by 25%. That means 75% of the patients on statins will go on to develop additional cardiovascular disease. In addition, those people who should have an LDL of less than 70, those people with established vascular disease, only about 28% will achieve that. And in addition, we're well aware, for those of us who clinically treat people, that there's the ongoing problem with statin myopathy. In clinical trials, they said it was 1 to 5%, but in observational cohorts, it was 11 to 29%. And in my personal experience, even taking a statin myself, myalgias are a very common problem, and a problem in the fact that you have very little to offer the patient who needs LDL cholesterol lowering. So I finished on time.